Good afternoon, everyone, and welcome to the Behavioral Health Echo series. This session is brought to you by the Center for Substance Use Training and Telementoring, CSAT, a division of the Be Well Institute here at UT Health San Antonio. My name is Andrea, and I will be helping to facilitate this conversation today. A few quick announcements before we start. This session is being recorded for later distribution. However, the information that you see on the chat will not appear on the recordings. So please continue adding your names, email addresses, and affiliations on the chat. We will use this information to confirm your attendance to this class. And as always, if you need captionings, you may always go to the bottom part of your Zoom windows and click on the captioning menu. And today we are excited to have Dr. Andrew Gaddis with us. Welcome, Dr. Gaddis. It's great to have you at Behavioral Health Echo. After Dr. Gaddis' presentations, we're opening the floor, as always, for your questions and comments. And then during the second part of the session, someone from the community will share a brief case with us. And please remember that the Echo space is a space of all teach and all learn. So we want to hear your perspectives, your opinions. Hopefully, our case presenter will lead the session today with some new ideas on how to manage the case. So please raise your hands, unmute yourselves, and take part of this conversation. So let's start with introductions. Leslie Manson, welcome to Behavioral Health.
Thank you, Andrea. Hi, everybody. I'm Dr. Leslie Manson. I'm a licensed clinical psychologist, a clinical associate professor, and an international consultant for building sustainable behavioral health programs into medical settings. So thank you for having me.
Welcome, Leslie. Dr. Antoine, welcome to the session.
Thanks for having me. Hi, I'm Dr. Dennis Antoine, a psychiatrist at Johns Hopkins in Baltimore. I'm director of a few of the substance use disorder treatment programs and also have the honor to work a little bit with our speaker today. Happy to be here and looking forward to the discussion.
Thank you, Dr. Antoine. Didi, welcome.
Good morning. I'm playing around here with my Zoom. It's changed somehow. I'm Dee Dee Stout. It's still morning here, so I'm in Emeryville, California, the home of Pixar Studios, for those of you that love those films. And I am an addictions counselor working in holistic harm reduction psychotherapy is what I do with individuals, families, and couples. What else? And I'm also an associate professor at St. Mary's College in Moraga, California, and I think an author. I have a couple books out. There we go.
And a lot more. We'll have time to talk
Yeah.
about that later.
That's
Thank you,
enough.
Didi.
Thanks.
We're certainly lucky to have you with us. Maria, she's our case presenter. Would you briefly introduce yourself to the group, please?
Yes, hi. My name is Maria Carballo. I'm a licensed professional counselor, and I'm with UT Health Heroes.
Thank you, Maria. And I think that now we can formally introduce Dr. Gaddis. Welcome to Behavioral Health. And if you could briefly introduce yourself and start with your didactics. Thank you.
Sure. Thanks so much for having me. I'm Andrew Gaddis. I'm a psychiatrist here at Johns Hopkins with Dr. Antoine. I work primarily in substance use and related conditions, and I'm also a postdoctoral research fellow at the Center for Psychedelic and Consciousness Research, which is in the department. I work on two large-scale clinical trials looking at psilocybin in its application for both alcohol use disorder and also opioid use disorder. And I have a couple of projects of my own, which involve peers, people with lived experience that I will talk about at the very end, and excited to be here. Thanks so much for having me. I'm going to go ahead and just share my screen and hopefully
Yes, we see
everything
it.
is working. Can everybody?
Yes, we see it. Perfect.
Excellent. All right. So the title of this talk is Interdisciplinary Collaboration in Behavioral Health with people with lived experience. I would add that this has sort of been adapted from another talk, and I probably have too many slides for the duration of this. So I'm going to try to like kind of move through, hit the highlights. Hopefully there's time for questions and we can always loop back, and my contact information is here. So if there's anything that doesn't get covered, please just reach out. And I believe a copy of the slides are going to be distributed. Um, I don't have any financial disclosures or any additional disclosures other than those here. There were some things that I did want to disclose, some experiences I've had working with people with lived experience in substance use that have been formative. So in addition to my current position, which I've already described, I'm the chair of the board at Charm City Care Connection. Those folks are pictured here on the bottom right, which is a really excellent community-based organization that's governed and largely run by people with lived experience, delivering low threshold harm reduction services at a drop-in center in East Baltimore. Just a brief kind of smattering of things before that. I was a medical student in Virginia and was one of the co-founders of Virginia Harm Reduction Coalition. Those folks are pictured up here on the top right, doing similar excellent work in the Appalachian region. I spent a year in Vancouver, British Columbia, working with also groups of people with lived experience, which I'll talk about a little later, and just kind of rounding things back out. And we'll talk a little about the work at Charm City later. Before all of this, I was lucky enough to be given a small grant to co-found and be the first executive director of Charm City quite a long time ago at this point. So looking forward to talking a little bit about that. Just a note, things I don't discuss or disclose or don't plan to would be whether or not I have current or ongoing mental health concerns, or whether or not I'm in treatment for these things, whether or not now or in the past I've engaged in substance use, legal or otherwise. So again, just by definition here, and I've included the SAMHSA definition of peer support on the top right. I am a behavioral health professional who does not provide peer support services. Just reading through this definition, which I think is an excellent one. Peer support encompasses a range of activities and interactions between people who share similar experiences of being diagnosed with mental health conditions, substance use disorders, or both. This mutuality, peerness between a peer support worker and the person seeking recovery promotes connection and inspires hope. Some really, really excellent quotes here. I really like the bottom one that just says peer support allowed me to feel normal. Last disclosure or non-disclosure, I am a registered peer supervisor here in the state of Maryland. Down on the bottom right is just a brief kind of overview of all the different certifications that you can obtain here in the state of Maryland. On the top right is a certified peer recovery specialist. Bottom right, highlighted in purple, registered peer supervisor, which you can obtain if you're a behavioral health professional like myself, a psychiatrist, and I do have some sort of complicated thoughts about that. But the last thing to highlight just in the top left would be the certified peer recovery specialist in the domain of family, which we'll talk about briefly later. Just to round out disclosures and non-disclosures, I did want to kind of include some suggested reading from some authors who are behavioral health professionals, but disclose somewhat differently, just moving left to right here in different domains. On the left, this is Kay Jamison, faculty psychiatrist here at Johns Hopkins, who wrote a very excellent book called An Unquiet Mind, in which she details her personal struggle with bipolar disorder and treatment and recovery from that. In the middle is a book called The Urge by Carl Eric Fisher, in which he details both the history and also his own personal struggles with substance abuse and recovery. He's faculty psychiatrist at Columbia, and on the right, kind of a controversial book, but Drug Use for Grown-Ups by Carl Hart, who is a behavioral health researcher at Columbia, who details his ongoing opioid use, which he does not view as disordered. So just some follow-up reading if anyone's interested. They're all excellent books and recommend. So the learning objectives here are to describe the history and the evidence behind the different types of both formal and informal support from peers and other people with lived experience, explain best practices and challenges associated with meaningful interdisciplinary collaboration between people with lived experience working as peer support specialists and other behavioral health professionals, and last, to identify some strategies and address challenges in emerging areas with academic and other interdisciplinary collaboration. I included just a smattering of the history. This is not necessarily a close to new, concept or topic. Some examples, just starting from the top, would be Native American recovery circles. These are groups of people with experience struggling with heavy alcohol use that was kind of brought over by European settlers and just mutual support groups. On the right is a photo, and I did want to highlight the Washingtonians, which was one of the early temperance groups that would just meet in a tavern, a bunch of folks struggling with alcohol use, and they wanted to better themselves and those around them by just talking through the different struggles here in a tavern in Baltimore. And that has, after that, led to a lot of different temperance societies, ultimately with the well-known Alcoholics Anonymous starting in 1930s and Narcotics Anonymous in the 1950s. Did also want to highlight some examples of the sort of formalization and professionalization of the work. Pictured as the Keeley Institute, where physicians themselves might struggle with substance use, but also seek to treat it. Quote unquote halfway house managers. I would also like to shout out an excellent recovery-based organization that I work with Dr. Antoine called the Helping Up Mission, which has all sorts of arrays of formalization of informal peer support. So that brings us to the 2000s, where there's been leaps and bounds in terms of progress, especially towards reimbursement-based work. Georgia in 1999, as I understand it, was the first state to authorize Medicaid billing for peer support services. Afterwards, and kind of in tandem with several rounds of SAMHSA funding, and in a landmark move in 2007, the Centers for Medicaid and Medicare Services cited the efficacy of peer support programs, which has since caused a robust increase in this type of work. Just a sort of recent state of affairs here, highlighted in orange, you can see there's give or take at least 40 states that have Medicaid reimbursement, and then in the blue square here, just emphasizing that the type of peer support can vary state by state. On the top, you can see Connecticut, at least at the time this figure was put together, had mental or behavioral health, but not substance use-based reimbursement. Here in the state of Maryland, again, at the time of this figure, at least, there was substance use, but not formal behavioral or mental health-based reimbursement. So there's a distinction there. These are some lovely infographics. So moving on to the evidence here. So in the red, you can see there's a host of amazing outcomes that are associated with peer support. On the right, there is sort of an up arrow and a down arrow here. I put the up arrow here in green, just showing that there is really definitive and robust evidence for certain things showing that engagement with treatment goes way up, and as does the satisfaction with services. I think all of that's really well evidenced, as is the rest of this, but there's a lot of emerging areas of research that hopefully we'll get to talking about a little later. But just in terms of looking at the different areas of work, getting rid of some preventable adverse health outcomes, unnecessary emergency department utilization, cost, et cetera, is also something that is an outcome that is associated with well-provided peer support. So other than outcomes, you can look at the evidence in terms of descriptive evidence. This is a survey of thousands and thousands of peers across a couple of different states asking them where they work. And you can see in blue, most peers still report working at either nonprofit organizations or community-based settings. But as you can see in orange and in green here, increasing number of clinical settings, academic settings, hospitals, et cetera. Looking specifically at behavioral health in different settings. This is a poll of a bunch of different behavioral health settings asking, whether there's peer support there or whether or not they perceive it to be a shortage area. And on the right, you can see where there's state level support or training in place for peers to work in certain settings. I've highlighted crisis center training here, which is the states in blue. So developing area, more support being provided, and exciting. In terms of roles, best practices, I would just highlight first and foremost, this is a core content area infographic from SAMHSA. And at the top, you can see that based on the purpose of the peer support provided, the type of population served, these core content areas are going to differ somewhat. So it really depends a lot on that, but some common things you see often would be running like a group for mutual support. In green here, connecting folks to community resources, but I put in bold here in purple, which I think is the most important thing, which is just the sharing of their personal recovery experience to make people feel not as other than. And on the top left from that same survey study is just a list of when you ask peers across the board what it is that they do. Most often, I think 11 out of the 12 of these are focused on the sharing of personal experience. So again, here are some sample work activities that peers might engage in across a variety of populations and settings. Would just emphasize again, that depends on the population served and the setting, but just giving some examples. Working with contemplative folks or in harm reduction, the focus might be outreach or motivational interviewing. Working in a clinical setting, inpatient or IOP, PHP, et cetera. The primary role of the peer may be advocacy and making sure that folks are being treated with a high quality of care. Moving to outpatient treatment, where doing exhaustive follow-up and checking in on folks is a very valuable activity. But again, there's any range of activities that folks might do that would be valuable. Last, I did just want to talk about like hiring and oversight, et cetera. This is a wonderful infographic again from SAMHSA over here, just highlighting the need for, in general, a recommendation for examination and certification, et cetera. But things that are still attainable, not exclusive of folks who can provide a lot of value in the workplace. Needless to say, education and training, accountability, and ethics are very important. And I did just highlight here on the bottom in red. I personally think that the provision of appropriate supervision, ideally by peers, is a really, really important point across the board. So highlighting some challenges here, again, really excellent figure here. There's systems level and individual challenges. Highlighting in particular on the systems level, it's often difficult for folks without a lot of experience there to integrate into demanding fast-paced clinical work environments. Also very difficult in terms of those environments to then kind of provide opportunities for advancement in that workplace. So that's definitely a challenge area. Individually, of course, there's stigma and misunderstanding from colleagues who may not understand, the peer support specialist or what it is that they've been hired to do, and again, limited kind of clinical professional experiences among peers. So this Exhibit A is just, I think, a pretty wonderful set of recommendations for supporting and expanding the peer workforce. In orange, first and foremost, which is something that I think is a really excellent best practice, is the creation of peer advisory boards, or looking out into the community for existing peer-based organizations or organizations of lived experience to help guide that type of thing. Boxed in green here are different examples of interagency collaboration that can really help. And last, here in purple, is the recommendation for interdisciplinary collaborative partnerships, such as in academia and elsewhere. So I'm going to focus on a couple of those for the rest of the presentation. So just dividing this up by area of focus here, starting with substance use in particular. Some areas that are being explored that I think are really exciting are just in increasing the scope of peer support and how that can work for people at different stages of change. I would highlight Be More Power. They're shown here on the top right. They're funded by the Baltimore Behavioral Health System. They're a group of people who use drugs who are able to help the city and the state make good policy recommendations. Pictured in the bottom middle is an organization called Vandu that I was lucky enough to spend some time with while I was in Vancouver. This is the Vancouver area network of drug users. I'll get into in a second an example of how they've worked with government agencies to forward research and policy. And then last, on the bottom left here is a highlight of some of the work at Charm City Care Connection. We have a tiered system of casual employees. Folks can start at HR1 and then move to HR2 and HR3 if they so choose. Because it's not a formal certified peer worker engagement, we don't require any sort of hard and fast abstinence or anything like that. So folks can be even pre-contemplative or very early in their recovery, but wishing to add value to the organization, and therefore can sort of move throughout this process in a way that gets them early employment towards actual formal peer certification should they choose. Just showing an example, which is a bit far from our reality here in the United States, but just an international kind of example of a group of people who use drugs working in government and policy. So basically in Canada, they have managed alcohol programs, which is something that we have on only a very limited basis or not at all here in the United States. similar to opiate replacement, Suboxone Methadone for opiate use disorder. This is for folks who can't stop drinking. Over there, they heavily tax their alcohol, and as a result, have a very serious problem with non-beverage alcohol consumption, which is very harmful. So they have these managed alcohol programs to address that, but similar to ourselves, they're contending with like more widespread medicalization and legalization of cannabis, and some reports that it can actually reduce alcohol intake. They sort of needed to set guidelines and policies about marijuana use in the managed alcohol programs. And so you can see on the bottom left here, policy folks would reach out and meet up with the folks at Vandu, and they'd have discussions about prevailing attitudes about that and how to best reach folks. And this resulted not only in policy guidelines, but also on the picture on the right here, some really kind of consumer-oriented, really approachable diagrams explaining the basic like need to know facts about this type of issue for folks that were enrolled in the managed alcohol program. So this is published in the International Journal of Drug Policy. I think it's a fantastic paper that describes both process and outcome. Just to highlight in behavioral health, where I think there's a lot of really exciting expansion of the applications of peer support. So just running from the top to bottom here, highlighted in blue is the same figure from before, showing the number of states with reimbursement. And this shows that 20 or so, give or take, states also have reimbursement-based systems in place for youth caregivers and family dynamic peer support. In terms of gambling and behavioral health addictions, on the bottom right, this is the Maryland Center for Excellence on Problem Gambling, where peer support is something that is provided and reimbursed for services. I believe that might be through restitution type money from gambling, but I'm not exactly sure. But it is definitely, I've come across numerous peers working in this domain, and they're really wonderful. Just for in terms of internet addictions, social media, gaming addictions, this is Professor Dr. Michelle Calder-Carras at the School of Public Health, is someone who is a peer and peer supervisor in that domain, and might often give a talk using this avatar of hers. So certainly something that can be applied in those types of behavioral addictions. And last, I did want to just highlight here on the bottom left, this is out of the Armstrong Institute, funded by PCORI, which is a patient safety organization. This is a project in which health behaviors associated with chronic medical disease like heart failure and COPD, diabetes, etc. This is an area that there's emerging evidence to show that peer support in these things is also extremely valuable and associated with improved clinical outcomes. So I'm just going to highlight two different peer integrated research programs here at Hopkins, one of which, I think I'm lucky to be put on the same slide. And just a disclaimer, myself and Dr. Antoine work on the second one, which is in its emerging phases, but much further along, much better developed. And I think a model really for the integration of peers in the research space is a program called Restore. This is recovery and specialty care through medication and outreach. This is a integrated clinical research peer team that is working in our longstanding infectious disease clinic, the Bartlett Clinic, working to help people struggling with HIV, hepatitis C, etc. And on the right and on the bottom, you can see they've published numerous peer-reviewed papers that show a ton of really exciting outcomes across the board. Just running from top to bottom here on the right, the headline story here is, I would say that, there are clinical behavioral health and substance use related improvements that are associated with peer support. So at the top, you can see that folks who have engaged with peer support report less anxiety, more social connectedness second to top, less drinking below that, and then below less heroin use and less non-fatal overdose. And so I think the take home, for me at least here, and working a little bit with that team is that, I think the integration of peers into selection of the outcomes, design of the research looks at these outcomes, and also in the actual practice of delivering the services to patients is really essential. And I think that's what's going to sort of make the evidence a little less one way or another with regard to the given outcome that you're looking at in any particular domain. And just very last, would highlight that, we talked about how increased engagement is a huge piece of this. I personally, again, I'm going to highlight the opioid use study because that's probably the highest bar that we have. But you can imagine that the idea of, doing psilocybin, the active ingredient in the psychedelic mushrooms, might kind of give people a little bit of pause, and so it's something that a lot of folks just kind of on paper, will not engage in a discussion about. They won't entertain the idea, and that's totally well reasoned and understandable. Unfortunately, in an area like psychedelics where I work, it's yeah, unless you take purposeful calculated steps to address that, you're just going to wind up with like a very homogenous population of people in your research, which just completely limits the generalizability of said research. So we've engaged a group of peers who first kind of attend informational groups and then are invited to participate as peer facilitators. And basically what we see, which we would hoped, but it's kind of an emerging area, is that compared to our usual very, very, very homogenous population, almost all of whom have either done psychedelics or at least very, very familiar with them, the peers themselves and the folks that they've talked to about this issue are much more psychedelic naive, much more diverse, much more heterogeneous. So and the last thing I would highlight is, which again was not something that we enforced, but we just asked, and we were really glad to see that although there were lots of very skeptical questions and whatnot, the majority of the peers that we've worked with did ultimately say that if they were provided with the appropriate amount of information to share, that they would be interested in talking more about this research potentially with folks that they work with if they feel like it's a good fit. And I believe I'm only a minute over. I'm gonna
You're
stop things right
okay.
there.
You still have a couple of minutes. It's
Uh,
great information.
I guess just to summarize, the formalization of peer support services in the way that we currently know it is definitely based on a long history, but is in its sort of formative phases and is a shortage and growth area. You can see that. Oh, woo, there we go. In this figure here on the top right, this is just the number of Medicaid beneficiaries receiving each different type of service, and peer support is all the way down here at the very bottom. So hopefully, lots of growth and an area for opportunity, particularly in behavioral health, who are early and leading adopters. And I would just say that the interdisciplinary collaboration, academic or otherwise, is a huge area with great opportunity. And we'll end there and take any questions or curiosities anyone might have.
Thank you, Dr. Gaddis. We're opening the floor for questions. There is great information here, and I want to remind our group that we are sending this information after the class. Questions, please, or comments.
Dr. Gaddis, appreciate the presentation as always. Just wanted to get your take on things. What have you seen in the clinical realm, in terms of a personal lived experience, in terms of how they've changed maybe the course of how a person might engage in treatment? How have you seen that play out?
It's a really excellent question. And I guess just kind of touching back on the relative newness of some of this, it wasn't that long ago, although I may have like a few more grays in my beard than most people at my stage in training, that I was an intern, over where Dr. Antoine is attending right now in the dual diagnosis unit. And there most certainly was not a peer working on the team. And I can distinctly remember a lot of folks that I think wound up leaving too early without the appropriate level of community support, didn't necessarily want to, engage with someone like myself, who's, from their perspective, especially not been through it and can't really connect the dots in the way that they would like to. I had the opportunity last year for a month to come back and attend on the unit, where there is now robust and excellent and very high quality peer support. And I was just really struck by the sort of new flow of the way the unit works, where folks might raise their eyebrow, and they maybe the rapport with the team takes a little while to build, but just having that moment where afterwards there's sort of peer rounds, and folks' thoughts and opinions are more honestly probably discussed in private with several of the peer workers, and very often there'll be a sort of callback after a difficult interaction in the morning, right, where there's sort of a revisiting of everything with someone. And and I just have really, really appreciated seeing the before and the after there. So I guess that's one perspective I could share that speaks to the value of having a peer on the team, or at least one, if not multiple.
Edie.
I'll jump in here for a minute. Thank you so much, Andrew. Appreciate all that. And the irony for me, having been in this field for almost 40 years now, I started out, I was trained at a hospital here close by in Oakland, and we were in a separate building for the sort of drug treatment portion, and the emergency room was half a block away from us. And somebody had the brilliant idea finally that maybe in the emergency room or in the aftercare recovery room, they could call us and invite us over to have a conversation with folks. And they noticed that, lo and behold, people were not presenting to the ER quite as often. And sometimes they were even entering treatment with us or someplace similar. Back then it was just because all of us who were working in the field, you had to have lived experience. That was your qualification. Some people barely had a high school diploma. It started to shift, and with a hospital, you at least had to get a bachelor's degree at some point. That began to change because of some of the core certifying bodies that were involved. But it was just called volunteering. That was peer support. And it's really nice to see it shift even more. I mean, we've done it here in San Francisco Bay Area for, gosh, I think about 25 years, maybe 30. But there's been a lot of discomfort, we'll call it, from a lot of the professionals, right? Saying, who are these people? They're not trained, or they don't have the training that I do. So why should I be listening to them? And then there's the whole idea of, oh, they're drug users. I like to say I'm forever going to be a dirty drug user in some circles. That doesn't change no matter what letters I have past my name or how many years it's been. And I can live with that at this point. I don't really care, but I can appreciate it's difficult. And now in California, we're seeing a real dearth in even substance use counselors. People are not replacing those of us who are aging out, retiring, dying, whatever the reason is, get tired of the field and the low pay. But there's nobody else coming up, let alone peer support. And we're very concerned about that and not seeing a shift.
Yeah, and it is my hope. I mean, I think we're very lucky, like, working with Dr. Anton, like we have these amazing peers that are able to, deal with an environment like you're talking about with the emergency department, which is stressful and fast paced. Like even for myself, I don't like to work there, it's a pretty high bar, and I've been amazed at like the way people are just able to step into it so naturally with so little experience prior. But I do hope, and I think a great example that I hope you've either already heard about or will hear about at some point from Dr. Antoine would be, like working on meaningful engagement and relationships with organizations in the community that have been doing this for a very long time, are based in a workplace that fosters growth and support and whatnot. And, the relationship with the Helping Up mission through the Cornerstone program that I'm lucky enough to provide mental health services a day or so a week at is like, I think, a really excellent example. And yeah, I think at Charm City, we've kind of gone back and forth and struggled with this. We don't really have any like formal academic relationships or, relationships with any clinical settings. Peer support is something that the organization's been based in since almost its inception. And so I think they're sort of in the throes of just discussing like, okay, well, what are the benefits of creating a more formal relationship here? What are the costs, and what are the challenges? And but it would be my hope that one thing to do is to obviously continue to make as many strides as possible to make formal clinical environments more welcoming to folks with backgrounds that aren't the same usual letters and same usual path. But it's also my hope that looking outwards for folks and organizations and places that have been doing this very well for a very long time is the direction that things go.
Thank you, Dr. Gaddis. And I think in the interest of time, we're going to be moving to announcements, but definitely there are some pieces in your presentation that I think we might go back during our case presentation. Just to remind our learners that to claim your CEU credits, what you have to do is to answer the post-session survey, and please answer yes to the question related to CEU. And a certificate for you will be issued 2 weeks after today's session. But just a quick reminder to all our learners that the post-session survey is not just for those who are applying for CEUs. Our post-session survey is a great tool that we have here at CSTAT, at the team, to get to know you better and to know what are the topics that you want to hear about, what type of cases, or even if you have any questions or suggestions and the way we deliver this material and these sessions. So please take the time. It doesn't take much. Just let's make sure that we answer that post-session survey because it's the only way that we can help you to serve others better at your own practices. So we're sharing the post-session survey link with you in the chat. And please remember, we're sending it via email right after this session. And thank you for supporting us with the post-session survey. Thank you to all. Next, please. And we're always looking for case presenters that would make it really easy because we provide you with a case form. What you have to do if you or someone in your team wants to present a case with us, just send an email at csat@utesca.edu. Next. And BWO Texas is now accepting applications to expand access to office-based opioid treatment or OBOT medications for opioid use disorder. If you are interested, please just access this QR code. And if you have any questions, there is a section in the link specifically for Q&A. So please add your questions there and someone from our team will get back to you. Great opportunity for everybody. Again, there is a Q&A part on that link. Thank you. Next. And CSTAT is always offering free technical assistance. This is a free service for all in the community. If you need technical assistance from us, just go to our website and complete that TA form, and someone will get back with you shortly after that. Next. And the Texas Substance Use Symposium is back, and we're so excited about that. We'll see you all on March 2 and 3 at the Henry B. Gonzalez Convention Center. Please don't miss it. Save the date. And please remember that we also have the El Paso event coming up soon also. So you will be receiving emails and more information. Be on the lookout for that. So we'll see you to those two events. That's the Texas Substance Use Symposium next year, but for sure the El Paso Summit coming soon. Be on the lookout for more information next. And as you all know, the Texas Hill Country just was recently ravaged with flooding. So if someone you know, or you yourselves need any help or any support, if you live in that area and you were affected by the floodings, please use these links and these resources that we're sharing with you. Also, if you want to help us, if you want to help the families at Carroll County and the surrounding areas, all these resources are going to help families in the area, and we appreciate in advance your help. Any help that you give to the families at Carroll County and the surrounding areas will be greatly appreciated. Next. And of course, next month, here at Behavioral Health, that's August the 29th. Don't miss it. And I think we're ready to share the case form. Just a quick reminder to our case presenter that during our case discussion, we'll never share any information that would help us identify the person in questions. I know we all know this, but we have to always just mention it again. But besides that, Maria Carvalho, if you're ready, I think we can share your form. And if you could quickly walk us through this case. Thank you.
Sure. Okay, does it look good?
Yes, you can make it a little bit bigger, probably. You can zoom in, that'll be great. Perfect, that's it. Thank
Okay,
you.
you're welcome. All right, guys, so today I want to present you with the case of DP. So DP is a participant of HEROES, which HEROES is an outpatient program for substance use. So DP is a 31-year-old white male. He has a long history of substance use, basically has used like everything in the books. His substance use started at the age of 13 when he was prescribed hydrocodone by the dentist. He reports he didn't feel he was addicted to opioids until he was 24 years old. His DOC is heroin and fentanyl, although he's been abstinent from that for a little over a year and a half. So he's currently using cocaine, hallucinogens, and street ball Adderall. And so, out of like in today's meeting, what I would like to get out of is maybe new suggestions for motivation for change, and also maybe new strategies or psychoeducation that might help reduce resistance and increase follow through. So, in terms of like his current challenges, my client current challenges involves ongoing minimization and justification of his substance use. So he continues to express resistance to change by stating that his use helps him with his creativity. So he creates music and art. In addition to that, he struggles significantly with following through, especially when it comes to seeking psychiatric care. We've had like multiple discussions about the benefits of getting an eval, and he just continues to delay and procrastinate in taking these important steps. And what I've noticed is that this resistance is a barrier to his overall progress, especially because there's been like noticeable depression symptoms over the past 6 months. Um, in terms of his goals, my client's overall goal is to remain abstinent from heroin and fentanyl, which he has. And he's been working with me for about a year. And at the beginning of the year, his use of cocaine and hallucinogens and street ball Adderall, which he continued to test positive for meth, he didn't see it as a problem. However, most recently, like his thinking has shifted in a more positive direction. What I've noticed is that in the past 2 to 3 months, he has been viewing it as a waste of money and time. And he also reported that he does not like the way that it makes him feel, noting that it makes him feel aggressive and angry when he uses.
Yes, I was going to say, Maria, if you want to, you can scroll a little bit down so we can also see all the parts of the form. Thank
Okay.
you.
So, his some of his strengths are that he displays a lot of honesty. Like he's been really honest about his substance use and reasons for it. He's also very family oriented. He's been working really hard with like repairing relationships with his parents and his older brother. He lives at home with his biological dad and stepmom, which, in my perspective, I feel like it enables his use because there's just no accountability there. In terms of like the strategies and the interventions that I've used with him, I've used motivational interviewing, a lot of like open-ended questions, a lot of affirmations, reflective listening, and kind of just exploring his ambivalence. We've also examined, of course, his coping strategies and most importantly, like his personal values. We've had like honest conversations about, are our behaviors aligning with our core values? So I feel like we've done a lot of internal work in terms of like exploring reasons for staying sober, but also exploring like his reasons for using. We've I've incorporated CBT to help him examine, right, the connections between his thoughts, his emotions, and his behaviors related to his substance use. We've done a lot of work with like replacing unhealthy thoughts, and a lot of behavior activations. We've also used solution-focused therapy to help him to help him to support some of his goals. Um, because he is a participant with Heroes, he receives peer recovery support services, which the coaches are an additional layer of encouragement and accountability in his recovery journey. And so, in my perspective, like I feel the strategies and the interventions used this far in therapy have been effective, because I've noticed that his ambivalence towards change has significantly decreased over time. And when he first started therapy, like, of course, right, he was minimizing his substance use and rationalizing in terms of like, helping him with his music and his art. However, there's been a noticeable shift in his substance use. So in the past 2 to 3 months, I've noticed that it's just he's only tested like positive once for cocaine. So that's a big win. Um, Oops, let's see. So this is his first time receiving like one-on-one counseling. He's had counseling in the past while in treatment, but he's only gone to treatment like twice. Then he didn't finish successfully, and this was like maybe more than like 3 years ago. He does attend some, in the past, he did attend support groups. And he does attend ours, which is like twice a week. He shows up pretty much every week. He has been on Suboxone for about 2 years or around that time. In terms of like his mental health symptoms, there's definitely some depression and mild anxiety, but more depression. He does have a history of trauma. Like he's reported that a lot of his friends have fatally like overdosed. And that's it. That's all I have.
Thank you, Maria. I appreciate it. Let's open the floor for the group to offer their ideas or anyone from the hub. Questions? Didi.
Thank you so much, Maria. That was very thorough. And I have a couple of questions that maybe you can help me with that I'm curious about. And the first one, I guess I'll start with is if his goal is to remain abstinent from heroin and fentanyl, and he's done that for 2.5 years, how come he's still with you?
Yeah, so he is part of our it's called Texas Mood.
Okay.
So yeah, so he needs to stay engaged with counseling, um, so
How
that
come?
he can get free Suboxone pretty much. Yeah, and he also chooses
Okay.
to stay with counseling because we've like
Yeah.
talked about moving down to like every other week or maybe
Uh-huh.
just checking in once a month. And he's enjoying counseling. He wants to continue to show up.
Right. Right. So, and that's great. It shows that you've done a lot of really positive things.
Yeah, we have a good
Yeah.
report.
Yeah, I can tell. One of the things as the MI expert here, I'd say, sometimes we get confused about motivational interviewing and think that the purpose of it is to help people to become motivated for the things we want our clients to do that we see as being helpful. And they may be. This isn't mutually exclusive, but that isn't the point of MI. And we see this all the time within our organization, it's called Motivational Interviewing Network of Trainers that I'm part of. And what MI is really designed to do is to encourage and increase one's own motivation. So, and I think you've done some of that with looking at his values and at the reasons why he might want to make a change. However, it also might be that we're kind of missing the idea that if he sees cocaine as positive for his, or if it's the psychedelics, I don't know, or all the above for his music and his creativity, that could be an interesting thing to explore. But you'd have to do it not from an abstinence bias.
Hmm.
That would have to be really tapping into him and why he would want to give up something that seems to be so helpful in his creativity and help him to look at another side. But again, make sure that that's not an outcome that I want for him. Does that make sense?
No, yeah, for sure. And that's why
Yeah.
like I thought he was a really good case to present,
Yeah.
right? Because right, what
Yeah.
we view as recovery, right? It's not how he's viewing recovery. So,
Right. Right. Great. Thank you. And thanks for letting me say all that.
no, thank you.
The last question I want to ask you is just if you know if he's tested positive for cocaine, if he's looking for cocaine, or if he's because you also said he's tested positive for amphetamines, or
Mhm.
is there some supply issue that's going on?
No,
And he's
yeah,
not sure what he's taking.
he's definitely seeked out cocaine purposely. And he's, seeked out Adderall purposely, but from using street bought Adderall, like he continues to test positive for meth, but he doesn't mean to test positive for meth.
Got it. Yeah. And that's what you would like him to see a psychiatrist for, is to get on to prescribed Adderall or safe supply Adderall
Yes.
or whatever the medication might be suggested. Okay.
Yes.
Thanks.
Yeah, thank you.
I hate to be the textbook psychedelic researcher guy here, but we're talking about creativity as a motivation for, ongoing substance use. And you did mention he has the hallucinogen history, which is a sort of vague term. And I'm just curious, like which ones, how frequently, why is he using these? You
Yeah,
know,
so his reason for it's mushrooms, right? And again, he creates music and art, and so he's like it brings out that, creativity in me. And I'm like, okay, like that's tough. I don't know how to address that, honestly, or have that conversation with him. So,
Any
I guess
ideas on someone in the group, to Maria's question, how to address that or how to start that conversation?
Well, I think there's a subtle part of it as to where he feels why he feels he's lacking in that at a baseline. I noticed that depression and anxiety are part of his history, and knowing the pharmacology of psilocybin, there happens to be some overlap with some antidepressant. So it'd be an interesting thing to see if that lack of pleasure extends to other areas and whether depression is what he's really trying to look for. Alongside that, I think there's a lot of opportunities just to see who he might be comfortable with, just to make him more comfortable to have these conversations and whether he knows what a psychiatrist would be doing with him, whether it's just for the medications or is it looking for the bigger picture, as I talk about with my folks about what else is going on that swath, whether it's the depression or an infection or whatever else that might be taking away his drive and his motivation.
mhm.
Dr. Gaddis, you were going to say something.
I guess it's just like you know, uh, I think it's really promising when delivered in our setting and completely different than recreational use. But it's nice working in like a sort of stigmatized substance. And I would say that, the fact that psilocybin is so far along as a potential approved treatment for depression, we're in phase 3 clinical trials right now. It is a nice sort of conversation starter sometimes to, I think people are enthused to not be like othered than for using psilocybin recreationally, but, you can sort of bridge using the research into questions of mental health, right? Be like, oh, this is really excellent. And folks tend to gravitate towards it for antidepressant effect. Like, is it possible that you're dealing with a depression? In which case, this is not just the one way to do it, right? So, I don't know. I think it's a good conversation starter that's not really, on stigma of substance use and kind of just more gets at the why and can like help people arrive at the idea that they're, using the resources that are available to them to address something like a depression.
And I guess that would lead into some of my thoughts too, are around that. Can he get connected with a clinic that is using psilocybin? That might be the handoff in some way, a warm handoff around that. And perhaps, I don't know if you can feel comfortable having that conversation, Maria, but if somebody if there was a local clinic or somewhere where he might be able to access that in a therapeutic setting, that might be something that would be helpful for him if he really wants to explore the use of that for all sorts of reasons, including perhaps his mental health.
Yeah, I haven't thought of that.
And also, obviously those, like, you have to be very careful about the level of safety and whatnot of it. It's not an approved treatment yet, and therefore there aren't approved clinics yet. But one thing that is approved that's like psychedelic adjacent and is an excellent antidepressant would be ketamine. So that might be something like to get in through the door of a psychiatrist. You should hopefully be able to find a local psychiatrist that might work in the ketamine space, and just drawing parallels. This ketamine is not like a classic psychedelic, but it's psychedelic adjacent. And I think people who are interested in psilocybin are often interested in that as well.
Leslie.
Thank you.
Just to piggyback on what everybody's been saying too, and it sounds like, Maria, you already identified that in the conversation with Dee Dee earlier. I feel like almost maybe perhaps the conversation is about resetting, as what you all are working on together, going over the successes that he's had, how he's met those goals, right? And then talking about what he thinks his new goals would be, things that are realistic, that are measurable, and maybe it's things that he needs to explore more in detail. And I think really going with his values, he truly feels and has these experiences that these things are helpful for him, right? And then acknowledging that, and then walking through that conversation about, like, tell me a little bit more about what that is for you. How, what does that look like? And then exploring that connection between other resources that might be there that might also help him to be able to have similar experiences. And then maybe connecting with other types of resources, even with psychiatric resources that might help him to be able to meet some of those other needs or values that he has or wants for himself. But just kind of opening it up as almost like, hey, let's revisit, where have we been, where we are, and then where do we want to go in the future? And that might take time, right? It might be, him really working as the decision maker, right? Obviously, in looking at all of these things, doing his own research, thinking about it. Maybe it's even talking with a psychiatrist or another professional to explore and talk about some of those things and risks and benefits, and that could be even an initial step, because there might be some fear related to what it means to go to psychiatry for a full, eval. And especially if he has all these lived experiences through watching friends that have died, perhaps they have also gone to, these other resources. Like maybe there's another trauma link there as well. And, kind of taking the time to think about just exploring it in terms of conversations rather than it's a place where now you're going to go for this.
Yeah.
That might be a helpful first step.
Thank you. I like that.
Thanks, Leslie. I think for so many of us who were former or current drug users, illicit drug users in particular, have had intersection with psychiatry at one time or another that wasn't client-centered, shall we say. And that can make us hesitant. And so there's a lot of stigma in that way and fear around that. So that might be an avenue that you could explore with him. Yeah.
Well, I think that Dr. Antoine, maybe you could give us a summary of the session and probably summarize also a couple of the recommendations and suggestions to our case presenter, to Maria.
Yeah, I think this is a great discussion overall from front to end in terms of a complex case of how to increase comfort with an individual that's been working towards different goals over time. But with Dr. Gaddis bringing up peers, individuals with learned experience as a key tool in that, I think that's something that needs to be taken advantage more and more in order to decrease any barriers to comfort, engaging in treatment, and consideration of different modalities that are up and coming and not all approved yet, but hoping as those things come around, that would increase our opportunities. With the individual that was presented today by Maria, I think there's a really clear opportunity to reinforce the work that has been done. They're still showing up, and that's an opportunity that shouldn't be lost. But just to make sure that from their perspective, they're being understood and meeting with the goals that they want to accomplish, and figure out the motivation of what could help things move forward there, whether it is a better understanding of what the treatments are that are available, or a better understanding of a support network with lived experience that is a healthy support that can move that forward. Whatever it might be that would enhance their comfort in moving forward is going to be the best thing, and positively reinforcing that along the way, creating that environment, if you will, to succeed. Those things, evidence-based or not always evidence-based, are going to be the key thing as long as they're salient to that person. And so sometimes that might not be what we morally want, but it is something that we ethically have to figure out what they are looking for to drive them forward to the success that they're looking for, not just the success we're looking for. I think that's the biggest thing, and a lot of developments to come in the future. So I'm glad Dr. Gaddis was part of the conversation, and thank you, Maria, for all the work that you're doing.
Thank you. This has been so helpful. Thank you so much, everyone.
Oh, we're glad. Thank you to all of you for being here today. Very special thanks to Dr. Andrew Gaddis for an incredible presentation, to Maria as well. And we'll see you next month. And please don't forget to answer that post-session survey. See you next month. Bye.